Orbital inflammations can be infectious in their origin as well as they can be non-infectious origin as well. Now, whenever we recall the infectious inflammations of the orbit, we remember that it can be of a bacterial origin, a viral, a fungal origin, which was known as mucormycosis. And on the other hand, we have the non-infectious inflammations of the orbit. Orbital cavity, as we all know, it's basically an apical cavity. Its apex is directed backwards, and we have the base, which is located anteriorly. So the inflammations can occur, usually they start off at the back of the cavity or at the apex of the cavity. Now, when you recall the applied anatomy of the orbital cavity, we remember that we have basically two important fissural openings lying at the apical cavity. So if there would be any sort of cellular infiltrates that would be collecting at the apical margin of the orbital cavity, that would lead to an inflammatory outburst at the apex of the orbital cavity. This outburst in return is going to cause the pressure symptoms on the structures that are passing in the superior orbital fissure and as well as in the inferior orbital fissure. Recalling the important structures passing through these important orbital fissures, we remember we have the optic nerve, we have the fourth and the sixth cranial nerves that were lying or that were passing through these orbital fissures, as well as important arteriolar supply that is basically supplying the orbital cavity, including the ophthalmic artery, the ophthalmic vein. All of these would have their pressure symptomatologies whenever there is an inflammatory reaction, whether it is of an infectious origin or either it is of the non-infectious origin. And that is the mainstay of our lecture today. We're just discussing the non-infectious orbital inflammations over here. So when we run through the list of the non-infectious orbital infections, we come across the pseudotumorous conditions that are very notorious. Now, what happens in these conditions? Usually when the patient comes up to you in your clinical departments, he or she would complain of the pressure symptoms. Obviously, there would be marked swelling, there would be proptosis, a painful eye, the ocular movements may be affected in these individuals. So either of these symptoms can be present in the patient whom we are treating. Now you have a range of differential diagnosis over here whenever the patient comes up to you. You have to basically broadly classify these patients. Either it can be a patient who is having a non-infectious state, an infectious state, or either it's a tumorous conditions. All of these would be at the back of your mind. Usually if it's a traumatic condition or if there is a hemorrhage at the back of the eye, the patient's history would reveal, or you would just quickly sort that out, that it's basically a condition of a trauma which resulted in a hemorrhage at the back of the eye. And obviously, this hemorrhage or this collection of blood at the back of the eye is causing the pressurized symptoms at the back of the eye. So this can be the multiple differential diagnosis that we have to keep in mind whenever the patient comes up to you with pressure symptoms, with the symptoms of diplopia, or either it can be the symptoms of chemosis in these individuals. On the other hand, if we just strictly consider what would be the particular features of a pseudotumor, that is basically not a tumor, but the symptoms produced are just resembling a tumorous condition, as well as when we'll be carrying out the radiological studies, for example, the CT scans or the MRIs, we'd find out that there is a mass that is lying posteriorly to the orbital cavity. That is the orbit has the pressurized symptoms due to a mass that is collected at the apex of the orbital cavity. It is basically the cellular infiltrates that are collecting over there. The fibrovascular chemosis that is occurring over there. We have the lymphocytic infiltration that is being collected at the apical cone of the orbital cavity. So this is the basic definition of the pseudotumorous conditions that we usually come across, and we should know how to deal with these pseudotumorous conditions. Now, what are the etiological factors towards the development of the pseudotumorous conditions? Usually it's idiopathic. And that is the reason this condition is also known as idiopathic orbital inflammatory disease, abbreviated as IOID. And we usually come across this kind of an inflammation in which there is no actual cause for the development of the collection of infiltrate or for the startup of the inflammation at the apical cone of the orbital cavity. So clinically, they usually present as the tumorous conditions. The clinical presentation or the signs and symptomatologies are quite obviously resembling a condition in which the patient is suffering from a tumorous condition. Histopathologically, it is proved to be chronic inflammation. So whenever you have these patients, you usually take a fine needle aspiration biopsy, that is FNAC. Fine needle aspiration cytologies are sent to the laboratory for the further investigations. And after you send these samples, you come across the fact that it's basically not a tumor, but rather it's an inflammatory reactions, because there would be the cellular infiltrates, there would be the mononuclear collection in this fine needle aspiration cytology that you have sent for the histopath, and you have further investigated the case. So it would be basically a sigh of relief for the patient that it's basically not a tumorous condition, rather it's an inflammatory condition, idiopathic in origin, which can respond to steroidal therapy, which can respond to the antibiotic therapy for the prophylaxis of superimposed bacterial infections in these patients. So idiopathic orbital inflammatory disease is another name or is another terminology that is given for this condition, which is known as the pseudotumorous condition. We have the lymphocytic infiltration associated PMN cell response that we usually come across in these patients. So it's basically the collection of the mononuclear cells, the lymphocytic infiltrates. The etiology is not known in these cases, but all of this collection at the back of the eye is going to result in the pressurized symptoms in these individuals. Now, moving on, we have the different sorts of clinical features for these pseudotumorous conditions. The patient would usually come across, and the age limit is, it's not quite a strict phenomenon in these individuals, but usually the patient lies between the 4th and the 5th decade of his or her life. The most cases we come across are unilateral. It's a unilateral condition, but of course it can be a bilateral condition. In a few cases, there is swelling or eyelid puffiness that is noted down. Obviously, this condition can be mimicked with a bacterial or a viral or an allergic condition. But the pressure symptoms, they start off very soon. The ocular movements would be affected, and that is going to result because of the fact that the optic nerve is compressed at the fissural margins. There would be an optic nerve dysfunction. The most important cardinal test over here is that you ask the patient to look in all of the 6 cardinal directions. And he or she is not able to move his or her eye in one specific direction. Either it's the lateral or either it's the medial movements of the eyeball. So that would be affected, and if there can be a severe prolonged inflammation which is not responding to any sorts of antibiotic therapy, any sorts of antiviral therapies, and even when the systemic therapies are given to these patients, they do not quite well respond to this kind of a treatment. Then there is another terminology which is known as a frozen orbit with visual impairment. So obviously, if the optic nerve is compressed, that is going to stop sending back the messages to the visual cortex, and that is basically the mainstay for the visual impairment in these patients. On the other hand, the fourth and the sixth and the third cranial nerves are going to be affected in these patients, and that is going to result in the inability or the ocular movements or the ocular motility is going to be affected in these individuals, and that is why the name frozen orbit is given for these patients, and that is the collection of symptomatologies or the set of signs that we're going to look for in patients who are suffering from a pseudotumorous condition. How are we going to make the diagnosis in these patients? We have to evaluate that this is not a tumorous condition that the patient is suffering from. On the other hand, we have to distinguish this kind of a particular condition from the other bacterial, from the other viral infections or the allergic conditions that the patient is suffering from. The ultrasonic and the CT scan showing the diffuse infiltrative lesions. So whenever you carry out these radiological imaging techniques in these individuals, you would find out that on performing the ultrasonography, the CT scans, and the MRIs in these patients, there is going to be a mass that is located at the back of the orbit. Now, this mass is obviously not distinguished from the cellular infiltrates or from the tumorous conditions, and you have to further on perform the fine needle aspiration cytologies in these individuals. The MRI is showing the hypo-intense lesion. Now, this is again very important that it is going to be not a hyper-intensive lesion, usually seen in cases of a mass or in cases of a tumor that is located at the back of the eye. Rather, it is the hypotensive lesions that would be noted down in the MRIs. Then obviously you cannot completely distinguish these shadows that we see on the radiological imaging techniques, and you have to perform some sort of an invasive techniques such as the biopsies, or you have to perform the fine needle aspiration cytologies in these patients to distinguish this condition. We can perform an incisional biopsy even in these patients. It is going to be a lateral approach to the orbital cavity. That is the most easiest way to approach the retrobulbar cavity and get the incisional biopsy, or you can get the cytologies for further investigations at the laboratories. The treatment guidelines over here, we have to treat the idiopathic inflammation that is occurring at the retrobulbar space. Obviously, we have to treat the patient symptomatically as well. Whatever discomfort, or there is puffiness, there is this allergic reactions, chemosis at the conjunctiva, or on the whole, it can be the whole of the orbit that is involved in the chemotic activity, or there would be the redness, the swelling, the irritative signs that are quite visible at the orbital margins. So you have to hamper down this allergic reaction or this inflammatory reaction that is taking place at the orbit. For this purpose, you can treat the patient symptomatically as well. For that purpose, you're going to give him or her the NSAIDs, that is the non-steroidal anti-inflammatory drugs. So this is a group of drugs that we can just, by the use of which we can just hamper down the inflammatory reaction that is taking place. Moving on, we'll be using the systemic steroids over here that we have to hamper down the inflammatory reactions at the retrobulbar space as well. And for that purpose, we're going to give the IV steroids to the patient. We have the cytotoxic agents being used in these cases. The tumor necrosis factor inhibitors, as we've already focused on the fact that it's the mononuclear infiltrates that we are focusing on, or that are being collected at the retrobulbar space. So we can use the tumor necrosis factor over here, although it's not a tumorous condition, but still the fibrovascular growth that is occurring over here can be jotted down. The fibrinolysis that is occurring at the retrobulbar space, that can be stopped by giving or by prescribing these TNF agents. Finally, we can even resort to, if it is a non-responsive case to any of these systemic steroids, to these cytotoxic agents or the TNF agents, we can use or we can prescribe the patient with the radiation therapy or with the radiotherapy as well. So this is quite a borderline, as you can even evaluate from the kind of treatment that we're giving to the patient, that this condition, which is known as a pseudotumor, is a borderline between the tumorous conditions and the infectious or the inflammatory conditions. The treatment would consist of the agents that we're using in any of the inflammatory conditions, as well as the common treatment guidelines for the tumorous conditions in these patients. When we are listing down the different causative factors towards the idiopathic inflammations, or either it can be the non-infectious inflammatory conditions at the apical margins of the orbit, we have one of the most notorious conditions, which is known as the Tolosa-Hunt syndrome. Now, it's quite an interesting condition, as the name is indicating. Again, it's an idiopathic inflammation that is occurring over here at the apical margins. The etiologies towards the development or towards the collection of the cellular infiltrates at the apical margins is not quite well known in these conditions of Tolosa-Hunt syndrome. It's the collection of the fibrinolysis that is occurring at the apical margins, as well as the inflammation of the orbital septum. So you have to remember this at the back of your mind, that it's the orbital septum that is involved in the inflammatory reaction, the collection of the fibrinolysis, as well as the cavernous sinus is involved in these kind of syndromic conditions. That is why the word syndrome is used in the terminology over here. Rather than the inflammation of the orbit, it's the inflammation of the cavernous sinus as well. So this is a very important point that you have to remember whenever you see these patients. You have to see the signs of cavernous sinus thrombosis collectively or grouped together with the signs of the orbital inflammation or with the signs of the retrobulbar inflammations. This would be the most definitive explanation or the most definitive definition towards this terminology, which is known as Tolosa-Hunt syndrome. So you look up for the signs that are giving you a collective picture in a patient. The etiology is quite not well known whenever you see these patients. So usually the patients would come up to you with the typical signs of ophthalmoplegia, pain that is usually paraorbital, involving the paraorbital muscles as well as the muscles of the orbit, and that is why resulting in this particular kind of an ophthalmoplegic picture. When you ask the patient to look into the 6 cardinal directions, he or she would or be not able to look in either of the directions, whether it is a downward gaze or whether it is an upward gaze, a sideways, laterally, sideways, medially. Any of these can be affected in the patient depending upon the nerve that is being compressed at the orbital fissures. The orbital fissures involved can be the superior orbital fissure or the inferior orbital fissure, but most commonly it is the superior orbital fissure that is involved in these patients, and that is why the name, that is the superior orbital syndrome, is given in these patients. As well as, on the other hand, in which there is a massive inflammatory reaction that is taking place at the apex of the orbital cavity. We call this condition as the orbital apex syndrome in these patients. So there is a subclassification in Tolosa-Hunt syndrome. On one hand, we have the superior orbital fissure syndrome. On the other hand, we have the apical syndrome. In the apical syndrome, we would have all the signs of superior orbital fissure syndrome, including the signs of the inferior orbital fissure syndrome. Now, the etiology and how does it occur? Is it curable or not? These are the common questions being asked as a clinician. You should ask these questions to yourself. What caused this condition is not quite well known. Again, it's a syndromic condition. It can be usually there is a genetic predisposition towards the development of this kind of a Tolosa-Hunt syndrome in these individuals. So there are a lot of studies, there are a lot of researches being carried out upon the Tolosa-Hunt syndrome. And the researchers have concluded that maybe it's a genetic predisposition and there is a role of the genetics quite importantly being played a pivotal role towards the development of this kind of a syndromic condition in these patients. But that is still or yet to be discovered in a more particular way. So you usually come across this patient, again, there would be the signs of inflammation, there would be the signs of chemosis, redness, puffiness, the orbital muscle paralysis noted down in these individuals, and there would be a constant headache that the patient would be suffering from. This would be a para-orbital headache that the patient would usually be suffering from. So that would be a typical picture of a patient when he would come up to you, a chronic headache, ophthalmoplegia, redness, puffiness, swelling, signs of pressure symptoms. All of these would be noted down by the individual. Usually, the set of clinical features or the set of symptomatologies that we usually discuss is being distributed into the orbital apex syndrome on one hand, and on the other hand, we have the superior orbital fissure syndrome that we have to keep in mind. Whatever the case may be, you have to remember that it's usually a self-limiting disorder with only mild ophthalmoplegia being left behind at the end of the treatment or when you send back the patient at home. There can be some sort of relapses seen in the patient as well. So mostly these signs would go away with the particular treatment, with the particular radiotherapy or the systemic steroids that we usually prescribe in these patients. But there can be relapses and remissions being noted down in these individuals, and these signs and symptoms can reappear in these individuals. The reason behind is basically the genetic predisposition of the patients towards the development of this syndrome, and that is why the reappearance of these syndromic conditions can occur in these patients. When we say the orbital apex syndrome, as you can recall, we have the base anteriorly placed, we have the apex posteriorly placed, and there are quite important structures lying at the apex so that they can have the pressure symptoms over there. The features of the superior orbital fissure would be present in the orbital apex syndrome, of course, and there would be the early visual loss. Along with that, the patient would be suffering from the afferent pupillary defect as well. So this AFPD would be present in the patient. These signs or the symptoms of the superior orbital fissure syndrome would include an ipsilateral ophthalmoplegia being noted down. There would be a sensory loss disturbances whenever you perform all those sensory tests, especially in which the facial nerve is being involved, that are quite disturbed in these patients, as well as there would be ptosis. Again, this would be a very important sign. Lid lag is another word that is given to the ptosis. Ptosis is basically the drooping of the eyelid, which is termed as ptosis in these individuals. The pain is labeled as the retroorbital headache, so that would be the most important terminology being used by the patient or being used by the clinician, that there is a headache which is most importantly located retroorbitally. Again, the pressure signs or the pressure that is being put on due to the inflammatory reaction in the retrobulbar space is the cause of the development of this pain that the patient would usually complain of. It is obviously a curable disease. It is not that it's not curable, but the percentage of the curity is quite distinguished in different individuals. as we have laid the foundation that it's a genetic a predisposition, a genetic mutation, or a specific kind of genes are involved for the development of the syndrome, we know that the treatment would not be 100% result in these patients. We can just try on with the systemic steroids to hamper down the inflammatory reactions at the retroorbital apical cone area, as well as we can also imply the radiotherapy in these individuals. What are the typical agents being used over here? It can be the gadolinium that is used for this kind of a radiotherapy, the tumor necrosis factor. All of these conditions can basically hamper down the fibrinolysis that is occurring. The ophthalmoplegia would be cured to a much better level, and the headache or the pain can be cured. The symptomatic treatment would be given to the patient just to relieve the patient of the symptoms of pain and ophthalmoplegia and the symptoms of a puffiness or the chemosis, the lid retraction, the ptosis. All of these can be cured at a particular level in these patients of Tolosa-Hunt syndrome, but still the patients can come up with relapses. They can come up with remissions in either of the case if these treatments are given to the patients or not. So listing down the different causative factors of the inflammatory reactions occurring at the apical cone, we know that we have a very important endocrine disorder, which is basically a thyroid hormone disorder, hyperthyroidism. Usually the patients present with a kind of a syndrome which is known as TED, that is the thyroid eye disease. We also call it as the ophthalmic Graves' disease. We even call it as the thyroid autoimmune ophthalmoplegia. So these are the different terminologies being used whenever we have these patients of endocrine exophthalmos, and we usually come across. So the outward protrusion of the eyeball was termed as proptosis. We usually use the word proptosis, but whenever we are suspecting that the patient is suffering from a thyroidal disease and he has those proptotic factors, that is, the eyeball is displaced in the forward direction, then we call this condition, or then we term this condition as exophthalmos in these patients. Now, there are the range of signs that we usually come across, indicating the lid retraction. We can also call it as the lid lag. Then we have the puffiness being observed, and there are the different terminologies or the signs being used for this kind of a thyroidal eye disease. So this is a patient in which we see there is a slight proptosis, but it can be a marked proptosis in other patients in which we have a thyroidal instability. Although this is usually collectively seen in patients who are suffering from hyperthyroidism, but in a lot of cases, it is the hypothyroidism being subjected to thyroidal eye disease as well. The etiopathogenesis would be hyperthyroidism in 90% of the cases, and it can be hypothyroidism in almost 4% of the cases, that is very little. And in even euthyroid cases, we see this 6% of the cases in which the people are euthyroid and there is a genetic predisposition towards the forward displacement of the eyeball. There is this exophthalmos being noted down in these individuals. There is this particular pathogenetic factors. There is a pathological cycle that causes this proptosis and exophthalmos in the patients of thyroidal eye disease that we'd be discussing over here. So there is a thyroid stimulating inhibition over here, the IGF and IR. There is a thyroid stimulating hormone. There is a receptor hormone at the orbital fibroblasts, and it is the same as the thyroid stimulating hormone. So that is the basic reason. The researchers or the current studies suggest that this similarization is causing the orbital fibroblasts to multiply and obviously cause the fibrinolysis at the retrobulbar margins. There would be tissue edema noted down in these individuals, resulting in differentiation and proliferation of the fibroblasts at the apical cone, as well as the hyaluron and the cytokines being collected at the apical borders of the orbital cavity. We can have the T cell monocytes also infiltrated at the apical cone of the orbital cavity, as well as a marked inflammatory reaction would start off just by the receptor being attached at the orbital fibroblast, and there would be the multiplication factors, there would be the infiltration and the inflammatory reactions started off at the apical borders. So that would be the start of the thyroid eye disease in these patients. The apex would be included. There would be the orbital inflammation at the apex. There would be the pressure signs, the ophthalmoplegia, the lid lag, lid retraction, the signs of ptosis would be noted down. So all of this would give a collective picture of thyroid eye disease in the patients. So this is again another diagrammatic representation of an orbital fibroblast being activated by the thyroid stimulating hormone factor being attached over there, which is a similar factor. The IGF-1 receptors are also activated. The thyroid receptor, the TSH receptor antibodies, they have a similar configuration over here. They get attached to the orbital fibroblasts and resulting in the thyroid stimulating TSH receptors, that is, as well as there would be the collection or the activation of the cyclic AMP in the fibroblast, resulting in the multiple proliferations of the fibroblastic reaction. There would be the mononuclear infiltrates collection, as well as resulting in a marked inflammation in these patients. This would be the collection, or this would be the happenings at the biochemical level that are occurring over there. So this would basically result in the adipogenesis. So as we have already noted down that these multiple cyclic AMP reactions that are occurring over there, they're resulting in the cellular infiltrate collection, they're resulting in the inflammatory reactions, as well as they would start off an adipogenesis in this orbital adipocytes. On the other hand, what would happen is there is an hyaluronic acid synthesis, and that would basically result in the expanded orbital muscles and the adipose tissue collection at the retroorbital margins, as you can appreciate over here in this diagrammatic representation. There is the collection of the adipose tissue. There would be the cellular infiltrates lying at the retrobulbar margins at the apical cones, and there would be the forward pressure symptoms lying at the structures that are lying at the retroorbital margins, as well as there would be the pressure symptoms, and that would basically cause the orbit to be displaced in the forward direction in these patients. The risk factors over here that we can just observe in these patients, the females and the middle-aged individuals are usually affected by this kind of a thyroidal eye disease. Smoking is another risk factor that predisposes to the development of this kind of a thyroidal eye disease in the patients. As well as we have the autoimmune thyroid eye disease, which can further result in the development of the thyroidal eye disease as well, through the same mechanism, through the same pathogenetic factors that we've already discussed. The genetic factors, they play again a very important role. The HLA-DR3 and the HLA-B8 mutations, they play a very important role in the development of the thyroidal diseases as well as the thyroidal eye diseases in return. The clinical profile in these patients would include the ocular motility defects that would be noted down in these individuals. That is known as the Mobius sign. So if there is an ocular motility, again, you'd ask the patient to look in the 6 cardinal directions. So there would be the ocular motility defects noted down. This sign is known as the Mobius's sign. There's a unilateral elevator palsy noted down. The conjunctival signs would include a deep injection, a deep chemosis, noted down in these patients, and then there would be the signs of irritation noted down. The pupillary signs would include the dilatation of the pupils noted down in these patients. Clinical features of the upper lid would include the retraction, which is known as the Dalrymple's sign. Then the patient can be subjected to the fullness of the eyelids, known as the puffy edematous swelling, and that is also known as the Enroth's sign. We have the difficulty in eversion of the upper lid mostly. So that is usually due to the fact that the upper lid is easily retracted in patients, and if it is not retracted, then we call it as the Gifford's sign in these patients, as well as the blinking is affected. And there is an infrequent blinking and lid lag, which is known as the Von Graves sign. Now, due to all of these features, we have the retraction of the upper eyelid, we have the puffiness, and then there is an infrequent blinking phenomena. There is an exposure keratitis, which is one of the complications, this complication sequelae for the thyroid eye diseases. These signs and symptoms, they form the basis towards the development of complications in these patients with thyroidal eye diseases. Then the exophthalmos occurring in both of the eyes symmetrically, they're affected commonly in almost 60% of the cases. We have exposure keratitis as one of the symptoms. Sandy or gritty sensation is noted down in these individuals, as well as the patient would complain of lacrimation. Increased lacrimation, again, due to the fact that there is increased exposure of the eyeball, photophobia, that is the inability to enhance the light sensations, and then the optic neuropathy due to the direct compression of the nerve or its blood supply. So the pressure symptoms would be seen in these patients, and that would result in the optic neuropathy. The blood supply would be also affected in these cases of the thyroidal eye diseases. There is a classification that is given to the thyroidal eye diseases, and we usually call it as the no specs classification. Now, what basically happens is this is irrespective of the thyroid hormone levels, and it's depending upon the clinical presentation of the patient. The N stands for the no signs and symptoms. The O stands only signs and no symptoms. S over here stands for soft tissue involvement with signs. And then we have proptosis, which is well established. And then we have the extraocular muscle involvement. We have the corneal involvement. And lastly, we have the sight loss. So this is one of the way we classify the thyroidal eye diseases. There is a mnemonic, that is the no specs is given over here, and it's basically the gravity of the disease, how complicated the disease has progressed into, and at what stage the patient is lying. Depending upon that, we classify the patients accordingly due to this classification. The clinical course would be a congestive or active phase that would include the active inflammation with marked lid edema, conjunctival chemosis and congestion, which is also noted down in these individuals. We have increased exophthalmos noted down in these individuals. And on the other hand, we have the fibrotic or inactive phase, which is noted down. That ensues after the regression phase, and the eyes are wide and painless, and the motility is also affected. So depending upon whether it is an active disease or inactive disease, we'd see whether it is in what phase pathologically the patient is lying. The investigations would include the thyroid function tests, of course, just to evaluate whether the patient is hyper or hypothyroid or euthyroid. The thyroid autoantibody assays are done. The MRIs are done just to distinguish it from any sorts of tumorous masses being located over there. CT scans and ultrasonography also further clear the picture for the patients. The clinical activity score, basically we have pain, it gives 1 for the retrobulbar pain. We have 2 points for the pain on ocular movement. And the redness, we have basically 3 points, the redness of the eyelids and whenever it is conjugated with the redness of the conjunctiva noted down in these patients. So this is the clinical activity scoring system that is used by the clinicians. Then we have 5 points for swelling of the lids, 6 for the swelling of the conjunctiva, 7 for the swelling of the caruncle. There's the medial caruncle that is swollen in these cases. And then we have proptosis that gives 8 points, and that is basically complicating the case and just showing that the thyroid eye disease has further progressed in its complications. We have 9 for decrease in the eye movements by plus minus 5 degrees over 1 to 3 months, and 10 for a decreased vision, which is more or less one Snellen's line over 1 to 3 months. That is basically showing the fact that there is a loss of vision seen in these patients. The workup would include the field of binocular single vision would be affected, the field of uniocular fixations, and then we also perform the Hess's or the least charting method just to see the visual field, how is it affected in these patients. The non-surgical management would include cessation of smoking, artificial teardrops for the symptomatic relief, cold compresses are given, eyelid tapping, and then prisms to ease the diplopia. So this would be a non-surgical approach towards treating the thyroidal eye diseases. It would also include the gonadotropin 5% eye drops, systemic steroids can be prescribed, head elevations to relieve the swelling, radiotherapies, and there is a combined therapy with the symptomatic therapies. Sometimes you just prescribe the patient with systemic steroids, or sometimes you couple up with all of the other non-surgical techniques. The surgical management would include a 2-wall decompression, 3-wall, and then we also perform a 4-wall decompression. So it's depending upon the anatomical structures being relieved. When you recall, we just recall that we have a medial wall, a lateral wall, we have a base, and we have a floor. A roof, and then we have a floor, or it's also called a base. So the approach is basically then how do we decompress this cavity and relieve the patient of the pressure symptoms. That is the mainstay when we are performing the surgical management in these patients. Then we also perform the extraocular muscle surgery involving the inferior rectus recessions. And sometimes we perform the mollerectomies, blepharoplasties, just to inhibit the exposure keratitis in these patients. We perform the scleral grafts with LP receptions, levator recessions, all of these just to treat the lid lags in these patients. So the exposure keratitis can be affected. There is a recession of the eyelid retractors being done also, and that is one of the major surgical procedures being done. Now, we have another kind of a condition which is known as the cavernous sinus fistulas. There is a low flow fistula. As we all know, cavernous sinus is a very important communication with the orbital cavity. So it can be the lower flow fistula can be due to secondary to trauma, or it can be iatrogenic. And that is again, there can be this fistula can result in the pressure signs and symptoms at the apical cone of the orbit, resulting in proptosis, chemosis, or even the bruise being caused at the apical cones. On the other hand, we have the high flow fistulas develop in the elderly women, and it can also develop during pregnancy. It is a less pronounced symptomatology being seen over here. The diagnosis is usually selective carotid angiography is done just to see the outflow. The magnetic resonance angiographies are being performed just to taper off the signs of the tumorous conditions. The treatments would consist of the endovascular techniques over here, just to evaluate the fact that we have to relieve the patient of the signs and symptoms at the apical cone. So over here in this lecture, we just summarize the different non-inflammatory or the non-infectious inflammations that are occurring at the apical cone mostly, involving the superior orbital fissure and obviously involving the inferior orbital fissures. These pressure symptoms would have their particular signs and symptoms on the patient, and one should know how to investigate this particular case to reach up to the definitive etiological factor towards the development of of inflammation at the retrobulbar space, and what can be the complications of this kind of conditions, and how do we treat these conditions. So that is the end of this lecture. Thank you for watching sqadia.com.